Alaa, Dr. Yusuf Zahir, for their invitation to attend the Gastro Club. First of all, I want to make short about this lecture, that we know that our patient, cirrhotic patient, usually known as patient with risk for hemorrhage. But there is another possibility of thromboembolic manifestation in those patients, which is nearly equal, maybe more or higher than the risk of hemorrhage. So our patients with cirrhosis are liable to risk of bleeding and the risk of thromboembolic manifestations. And can we evaluate and assess this patient? This is in short about my lecture. So we'll start with the introduction that hemorrhage has traditionally been regarded as the most significant hemostatic complication of liver disease. But now, there is increasing recognition that hypercoagulability is a prominent aspect of cirrhosis. Elevated international normalization ratio in patients with cirrhosis and the auto-anticoagulation may not be protective from thrombosis. But what is the problem? We have to know the problem. Rate of venous thromboembolic in hospitalized patient around from 4 to 15%, and around 8-fold increase over that in general population. The incidence of deep venous thrombosis or pulmonary embolism in hospitalized patients with cirrhosis ranges from 0.5 to 6.3. It is a high incidence. Also, portal vein thrombosis represent around from 10 to 25% in cirrhotic patients. From these figures, we nearly face nearly normal patient, although it is cirrhotic, but it is nearly the same possibility of happening of venous thromboembolic problems. We will talk simply about hemostasis. Hemostasis is a fine balance between procoagulant and anticoagulant activities. Inadequate procoagulant with excessive anticoagulant lead to bleeding, but the excessive procoagulant and the inadequate anticoagulant will lead to thrombosis. Hemostasis plays a major role in bleeding from esophageal varices, which accounts for 80% to 90% of bleeding episodes in cirrhotic patients. It is predominantly related to haemodynamic factors, local vascular abnormalities, and portal hypertension with a major role for hemostasis. Usually when we visit in our hospitals, when we visit patients with bleeding episodes, we concentrate on the CBC and the bleeding tendency in the form of INR and APTT. So the possibility of the most common cause of bleeding in those patients is the portal hypertension and the local vascular abnormalities, and the hemostasis have a major role in these patients. Usually the coagulation process is a high dynamic condition, interwoven array that occurring in 4 phases: initiation and formation of platelet block, propagation of the clotting process by the coagulation cascade, and determination of the clotting by anti-thrombotic control mechanisms, removal of the clot by fibrinolysis. In those patients, cirrhotic patients who have increased the risk of bleeding, while this risk decrease the production of non-endothelial cell-derived coagulation factors, the factors which are produced by the liver in the form of factor 2, factor 5, 7, 9, 10, 11, and 13. Also, thrombocytopenia is one of the roles which is responsible for the bleeding risk. Altered platelet function, abnormalities of fibrinogen, and decreased thrombin activable fibrinolysis inhibitors. All these factors make the cirrhotic patient liable to bleeding. But on the other hand, all those patients are also liable to thrombotic risk. It decreases the level of liver synthesis natural anticoagulant, protein C and protein S. Antithrombin levels also decrease, plasminogen, elevated levels of endothelial-derived factor VIII and von factor and other factors. All these factors will help that makes our patient, cirrhotic patient, is liable to thrombotic. So, there is other factors which can help in the development of thrombosis, the development of sepsis, prolonged hospitalization and the bedridden, increased levels of antiphospholipid syndrome like a patient with virus C, and the development of HCC. Also, other factor is the massive use of diuretics, which prone the patient to hypercoagulability state. So, in liver disorder, especially cirrhosis, we have a disruption of these opposing pathways, leads to different potentially changing haemostasis. So the term of anticoagulation is an old dogma in cirrhotics, represented by an elevated international normalization ratio in patients with cirrhosis is unfound. So it is difficult to use this term now. Another problem is this patient. The relative balance or imbalance in this patient is not reflected in the conventional finding indices of coagulation, like the BT, the ABTT, or the INR. So how can we evaluate this patient or differentiate between the patient at risk of bleeding and the patient who are at risk of thrombosis? The lack of proper measurement tools to identify this patient who are prone to develop thrombosis. These are the usually used items or investigation in our hospital to identify the patient. Platelet count, bleeding time, and platelet function, INR, and ABT. Are these investigation can help us to differentiate between those patients who are liable or at risk for bleeding and the patients who are at risk for thrombosis. We will start with the platelet count. The platelet count detects the risk of bleeding only at extreme levels. No more thrombin potential is obtained above 100,000 platelet count, and 50,000 platelet count is sufficient to trigger the coagulation system. And once the platelet count decreases below the 50, and this is common in our cirrhotic patient, will trigger the development or the production of thrombin. So, thrombin production in case of thrombocytopenia is considered as a natural compensatory mechanism for the bleeding risk. Also, in liver cirrhosis, high plasma lipids, principal factor, von Willebrand factor, compensate for the reduction in the platelet count. This is the second mechanism. The first mechanism is thrombin, and the second mechanism is an increase in the von Willebrand factor. But platelet count is not useful for measuring this compensatory mechanism. Von Willebrand factor and factor VIII complex lipids are a marker of endothelial dysfunction and are proportional to the severity of liver disease, but they are not a specific marker of bleeding alone. Bleeding time, the second investigation we can use to evaluate our patient. Is it an accurate to evaluate our patient or not? We will see. Bleeding time is a test that evaluates primary hemostasis. It is influenced by platelet number and function, and by factors such as cell volume, platelet volume, and the blood urea concentration, and the vasoreactivity. That it can give false positive and false negative results. In cirrhotic patients, there is a weak correlation between bleeding time and the platelet count, and no regular association has been found between bleeding time and the bleeding risk. So, bleeding time is not a good tool to assess the bleeding risk in our patient. Also, no regular association has been found between bleeding time and the bleeding risk. The administration of desmopressin shortens the bleeding time, but does not reduce the incidence of variceal bleeding in cirrhotic patients. Third investigation will depend on it, the platelet function state, like platelet aggregation and adhesion tests. There is no universally accepted platelet function assay in cirrhosis. measuring platelet function has a handicap that they are standardized for normal number of platelets. Standardization, platelet aggregation, and the platelet adhesion test as a function of platelet usually leads to normal platelet count, which is not present usually in our cirrhotic patient. ABTT and BT were never intended to assess preoperative bleeding risk. Usually preoperative, our surgeon depends on bleeding time, initial time, BT, INR, and BT, evaluating the bleeding risk. But they are not used for this, actually. BT and INR were developed to monitor oral anticoagulant therapy, not to assess the bleeding risk. Also, ABTT was developed to investigate inheritable single factor deficiencies, such as hemophilia, and to monitor heparin therapy. Also, they measure only procoagulant factors and are insensitive to plasma levels of the anticoagulants and the congenital deficiencies of antithrombin or protein C or protein S present with normal BT or ABTT. So, from this rapid review about the use of investigation in the hospital, trying to investigate the risk of bleeding or the risk of thrombosis, this available investigation cannot help us in this room. There is a thrombin generation test, which measures the amount of thrombin generated in plasma as a function of the procoagulant drivers, but not the thrombin inhibited by the anticoagulant drivers, especially protein C. It is unclear for this test. It is unclear whether this test is useful in predicting bleeding or thrombosis in cirrhotic patients. And the assay is not widely available at present, and it is too complex for use in routine diagnostic laboratories. Even this test is not available in many hospitals and maybe not available in Egypt. So till now, we have no investigation which can help us. But there is trial. This trial depends on elevated levels of factor VIII as a procoagulant in combination with decreased protein C as an anticoagulant has been suggested as a marker of procoagulant imbalance. Whether this is in vitro by hypercoagulability is truly representative of what occurs in vivo remains to be established. يعني حتى الماركر ده اللي هو اندر ترايلز اللي هو بيمثل فاكتور ايه؟ لفاكتور البروتين سي لغايه الان اندر ترايلز مش قادرين يحددوا بيه هل هو ممكن ينفع او لا. So in conclusion, hemostasis in liver disease is extremely complex, and the main difficulty facing the physician in patients with liver disease is the lack of comprehensive test for clinical estimation of bleeding or clotting risk. From practical point of view, each patient should be assessed individually, taking into account the underlying cause of liver disease, other factors influencing hemostatic competence, and the clinical context. البيبر دي from ايزل under press بيحاولوا فيها ان هو يكومنت على الثرومبوتيك problems اللي happening in normal and cirrhotic patient and the patient with thrombophilia. Regarding the patient with cirrhotic, the recommendation is that don't use, in short طبعا, don't use heparin, don't use vitamin K antagonist. In management simply any patient with thrombotic event in cirrhotic patient, that you can use the low molecular weight heparins in a prophylactic dose in the management of complicating venous thrombotic manifestation in cirrhotic patients. And thank you.
Thank you, Professor Alaa, for this very interesting presentation.